It is wonderful to be here with everybody, spending your lunchtime with me for this presentation. And I understand there are going to be people who are not able to join us live that are going to be watching a recording. So welcome and thank you for catching up and reviewing this presentation as well. I'm very excited to be able to share this information. This is a presentation I've been able to bring to the Diocese of Orange in California, to the Diocese of Baton Rouge at a local parish. So it's a joy to bring not just the good news of Jesus, but also this information about a condition that there are many misconceptions and myths about, that is a disability of the brain that can be adapted to both the person who might be living with the type of dementia and their family and friends. So thanks for being here, because it's really a message of hope. We'll get into some specific things around the condition, of course, but overall it's a message of hope. So I hope that is what you take away with this. And the presentation, y'all feel free. I know people a lot of times they'll take pictures of slides, so you can of course do that. But we are going to make the presentation available in a PDF form after this is over, and Monica can give you instructions on how to obtain that. And also during the presentation, I'm going to refer to some things that would take many more presentations to go into. But so when I reference something, it will also be something that is available through Monica. So a handout is something I have for presentations, as well as some videos and links and whatnot. So let's get started. So I have no disclosures to report. And this presentation, as well as the ministry Catholic Aging, is consecrated to the Blessed Virgin Mary, especially Our Lady of Sorrows, who taught us how to suffer, how at the foot of the cross. She showed us suffering perfected, which is another concept we could meditate on, but don't have time to talk about. But it's something I think it could be very powerful for caregivers, how to suffer in perfection like she did. So we have at least 4 objectives. You're going to hopefully take away a lot more than these 4, but these are the 4 main objectives. We're going to describe the association between Alzheimer's disease and dementia. We're going to identify symptoms of dementia. We're going to describe normal or typical aging. And we'll also talk about next steps if you see symptoms in a family member, if you suspect them in yourself. We're going to talk about some ways, and the whole time we're going to interweave our Catholic faith and how that comes to bear and it should be a foundation for us in difficult times. Of course, in the context of dementia, but you could also apply a lot of this theology to any kind of suffering. Oh, and there will be an opportunity. There should be time at the end to ask questions through Monica, and she'll let you know when we get to that point. So, but be thinking about questions that you may have. Jot them down so you'll have them at the end. All right. So, what is dementia? Dementia is a broad term. It's a very broad term. You could even say it can even be called a syndrome because it covers a whole group or set of symptoms. And here on the screen, you can see I started with the one that people think of the most, and that's memory or recalling things, whether it's long-term or something that you just did. Typically with dementia, it's the short-term memory that is impacted immediately. And some people still retain, depending on the type of dementia, they'll retain that long-term memory for much of the disease. But it's that short-term memory that people notice first and causes a lot of frustration. Impairments in judgment. So when something, we hope that we have prudential judgment in all things. And sometimes people will do things that just don't make any sense. Communication. So dementia can impact both the ability to communicate, to speak and communicate messages, and also can impact our ability to receive messages and be able to decipher what people are saying. So right now, as I'm speaking words in the English language, y'all are deciphering them, and they have, they'll have different meanings to everyone, but, there's a common thread to what you're understanding right now. But that can be impaired with dementia. Orientation of time and place refers to knowing that you are on a webinar right now, that it's, in the 12 o'clock hour Eastern, where you are in your room. And with dementia, many people may actually travel back in time. In some scientific journals and even some of my professors, they call it time travel, because somebody might think that in their mind, they are, back decades ago, they're a younger age, and that can impact how they interact with family members, whether they recognize or don't recognize family members. Or even, we're speaking of place, someone might say, I want to go home. And even though they're home, they're thinking about a home from their childhood or sometime early in their life. So that's an example of orientation, or in this case, disorientation of time and place. Concentration. So hopefully everybody's able to kind of block out any distractions right now, and just really participate in this presentation. But someone with dementia may have difficulty doing that, difficulty reading. They might read the same page over and over in a book because they're having difficulty in concentrating and focusing on one thing. Visual spatial perspective refers to how our eyes and our brain decipher how close that coffee cup is on your desk, or how close that camera is, the keyboard, etc. Or when you open the refrigerator, how close the ketchup bottle is. Or if we think about it in a more stressful situation, how close or far away is that car in front of you? So it impacts all of these things in our brain. And then we can, many times we see social withdrawal. If someone is feeling symptoms, and we could probably all relate to this. If we were feeling that we had a lot of these impairments, we may feel less open to going out to social events, family gatherings, to church, or other things that we used to participate in. We may naturally isolate ourselves. So there are issues of people, of us isolating others with this condition, but also this self-isolation or withdrawal is something. So someone who usually enjoys being out with others, if they start sort of, not wanting to do that, that could be something to look into, along with other things. And then mood changes. Someone who was normally pretty quiet and easygoing, they may have a different, they may be sort of get angry a little more easily, that they're irritable, etc. And again, this could be because of some of the deficits that we just talked about. So one of the biggest questions that I get and that other professionals get is, what's the difference between dementia and Alzheimer's disease? And it's a wonderful question. Another way that I hear this question is, someone will say in a support group, they'll say, well, my mom has dementia, but it's not Alzheimer's disease yet, or it's not become Alzheimer's disease, indicating that there's not an understanding of it. And so it's not an opportunity to say, hey, you're wrong about that, but it's an opportunity to clarify most of the time. So that's what this slide is going to talk about. What's the difference between them? So before we get into that, as an example, you'd probably agree that these 7 lists of items right here are vegetables. I don't think a fruit snuck in there, but so those are things we would call vegetables. That's our category. Or we can do something similar to dementia, because dementia is an umbrella, just like vegetable is an umbrella, and it's got many different causes or diseases that will manifest in the symptoms that we saw on the previous slide. And some of these 7 conditions and diseases that we see right here will cause some or most, and some symptoms we saw on the previous slide you won't see in some of these diseases. And then sometimes a person could have both Alzheimer's disease and vascular. Someone could have Alzheimer's and Lewy body. So it's just one of the many examples of how dementia is something that's very ambiguous. Emotionally, there's ambiguity with caregivers and those with it, right down to the, what we understand medically about it. So Alzheimer's disease is what the statistics and research tells us. It's the most common, between 60 and 80% of causes of dementia are Alzheimer's disease, followed by vascular disease, which, as you might imagine, has to do with blood flow to the brain and impact there. Lewy body disease is a particular neosynuclein protein that's found on the brain. Just briefly about Lewy body, because I don't have a separate slide on it in the presentation. This can be one of the most disturbing types of dementia, both to the person with the condition and for the care partner. Many times, because many people have hallucinations, and not just hallucinations like, oh, there's an animal or there's a child, but paranoia, the police are out to get me. So really like disturbing things. Some of y'all or all y'all might be familiar with Robin Williams, who had Lewy body disease and went undiagnosed for his whole life. Basically, they didn't know what was going on with him. There's a great documentary called Robin's Wish that really chronicles that, looking back with interviews and talking to people, and really exploring and bringing awareness to Lewy body disease. And I see it quite often, and it is one of those things that is very, very stressful. But there's even hope with Lewy body disease. There's the frontal temporal types of dementia that could be behavioral, where someone who is usually meek and very well mannered, now they don't seem to have a filter in their behavior or the things that they say. You cringe at the things that they might say. You might say, like, okay, it might even be something where you're like, okay, we need to leave this situation now because they're being inappropriate as far as what they might say about someone that normally they would not. And there's primary progressive aphasia. Speaking of actors, Bruce Willis is someone that came out, I think it might be 6 months now. Their family came out, announced that he has PPA, and this mainly this will affect communication, not so much memory, but communication in word finding and other ways. Parkinson's disease, many people are familiar, I think, with the physical attributes of that: a tremor, a shuffling gait, and other things. And so in dementia is something that can happen. It won't happen in every case, certainly, but in many cases it will. It's very closely related to Lewy body disease, in that you could see some hallucinations, and there's other sort of complementary symptoms there. So hippocampal sclerosis, another, and then there's a combination of Alzheimer's disease or AD and any one of these conditions. And then there are even others that are less common that I don't have on here, Huntington's being one, and others. So there are physical changes going on in the brain. This happens to be, as you can see, a computer-generated graphic of Alzheimer's disease specifically, and neuroimaging. And what I want to point out here is, well, first I want you to sort of contrast these. You see how nice and plump and round, how tight those fissures are on the brain, or the lines. They become on the next side, they become larger. The brain is shrinking in size. And so you can see the physical thing. The challenge is that you can't see my brain right now. You don't know what it looks like. We assume it's like it's on the left, but we don't see that. So while someone's brain behind the skin in their skull, it could be atrophied like the Alzheimer's brain, but we may not know it. And we're relying on their seeing behavior. And actually for a long amount of time, if we could have conversations with people who have dementia, and we may not even pick it up if we're not with them long, but live with them or spend a week with them around Thanksgiving or Christmas, we start to pick up on some of these things. And herein lies some of the challenges, the many challenges around Alzheimer's, is that they look normal. I don't mean to say those who are living with dementia, they may look normal on the outside. They may be perfectly fit. They may not have any other condition, any other physical condition or disability, and they look like like anyone else that's young or in the workforce or out there volunteering, we can't see their brain. And so it causes ambiguity in us when we can't really we can't really understand, well, they look fine, but their behavior and their memory, they have these impairments, and that really, that really disrupts things for both the caregivers and the person living with dementia. And one of the most unintentionally hurtful things that that caregivers tell me that they hear is, oh, well, your husband looks completely normal. He looks fine to me. And that sort of invalidates, the experiences that the caregiver is having. And that, that just kind of adds to some of the, the grief and stress that the caregiver is experiencing. So it's all that to say, it's an invisible disability that, that everyone here on this call recognizes as something that's important. And hopefully we can spread that awareness to others with hope. So let's talk about typical or normal aging. These are certainly things that I do. These might be things that you do. Walking into a room and forgetting why. Misplacing keys or your reader glasses if it's not something you wear all the time. Whatever that object is, you left it somewhere and now you can't find it. Occasional errors in billing, paying too little, paying too much, or thinking that you paid something unless unless you're very detailed with that. Or searching for a word or someone's name. You see them across the room and you're like, oh wait, I know who that is. The thing is with these is that we say this is normal or typical aging because this does happen to all of us. We're all very busy. If you look on the right hand of this slide, you'll see that, we all are trying to multitask at times. We all are under some kind of stress, and we're just thinking about a lot of things. So our brain does, as we get older, our brain does need a little more time to sort of get things going and to recall some things, but they're not in a way that disrupts life, or, whether that's our work life or our retirement or travel or anything like that. So we'll talk more about some of those symptoms, but if you experience these things like I do, you can rest assured that it is normal. So we, for example, we retrace our steps and we find our keys, or we leave the pantry and then we come back and then we realize, okay, I came in here for this particular ingredient or item. All right, so let's talk about the warning signs, and I'm going to use what are called instrumental activities of daily living to demonstrate and offer examples. So before I go into these instrumental activities of daily living, or ADLs, just a brief word about the ADLs, or the activities of daily living. These are things that we do that most of us are able to do. We don't even really have to put a lot of thought in it, and that's bathing ourselves, dressing ourselves, feeding ourselves, ambulating or walking, and there are a few others. But these, you probably agree, these are things that I did. I got dressed today. I did pick out what I was going to wear, but I tied this tie like I have always done it, and I did it pretty quickly. I didn't have to think about it. So those are things that are going to impact someone living with dementia. And actually, most of us, as we get older, just because we start to lose muscle mass or the ability to do things. So, but right now we take them for granted. So, but I'm going to use these instrumental ADLs to sort of talk about things that we should be able to do, like for a really long time. But when these things start to slip, or they start to become things that you're not able to do, they start to become a problem. These are sort of red flags. Or maybe yellow flags is a better word to say, to start kind of like keeping notes, keeping track of, okay, I saw this, that was kind of odd, so-and-so has been using a phone for a long time. So-and-so went to the grocery store with a list and they came back with only 3 things, and they came back with all these extra items that have nothing to do with what the plan was. Someone who has prepared food and made their they're known for this recipe in their family, and now they can't do it, or it's a lot more difficult. They might need to read it. read the recipe now, whereas they basically wrote the recipe before and they can just kind of do these things. Operating the washer and the dryer, driving's a very important one, very important to our independence. Managing money, where you're seeing a lot of mistakes with managing money. So these things, like kind of taken as a whole, these are yellow flags to start to wonder, should there be a checkup for myself or for my loved one? And here I have at the bottom, what I have learned over the years is that a social conversation with someone is usually insufficient to detect anything. And what do I mean by that? So if you are if you're in California and your mom is in Louisiana and you talk to mom, even if it's every day, if things sound fine, you don't know what the food looks like in the refrigerator. You don't know how old it is. Does it have, should it be thrown out? You don't know what her driving is like. And we attribute that to just the brief amount of time, not being there in person to lay eyes on them, and not being able to do it for a long time. There's something that Teepa Snow, who's a big trainer of a positive approach to dementia, and she calls it social chit chat. So that tends to stay intact. The right side of the brain has things like social chit chat. Oh, hey, how you doing? How's the weather? We do these. This is almost a conversation you could have. If you slip into it, any of us could have a social chit chat conversation without thinking about it much. We shouldn't, but we do sometimes when we're busy. And so on that part of the brain, it sort of has these pleasantries that we have. But the good thing is on that side of the brain, we have prayer, poetry, music, some great things that we can use to help those who are living with dementia. So if you have concerns, and not everyone, I know not everyone, and I'm not speaking about the people here on the call, because you're here on the call, you're showing initiative. There are people out there, believe it or not, that even if they saw these symptoms, they would not want to know that their loved one has an actual cause of dementia or not. They wouldn't. They don't want to chance it. I think it's still the majority of people that would want to know, but it's still very disconcerting, and I think it takes virtue. It takes courage to take steps when you see some of these yellow flags. So the first place that I recommend, and I've shopped this idea to primary care physicians, to neurologists, the best thing that I've seen is that if you see these yellow flags, you first go to primary care. There's a few reasons for that. Your primary care physician presumably knows you really well. That you can consider them the quarterback of your care team, even if you have specialists. It's usually easier to get into the office of your primary care physician as opposed to specialty. And most are still knowledgeable in doing some basic screenings. Based on what they find and what their concern is, they can refer you to neurology or neuropsychology. Now, I'm not suggesting that you don't go to neurology if you have memory concerns and you want to go straight to neuropsychology or neurology. If that's what you choose to do, that's fine. You just might be waiting a little longer, and they're going to want to refer to your primary care physician too, or at least speak to them or look at the record. So when you get to neurology, you may see a neurologist, or if you go to a large health center or health system that has neuropsychology, it's neuropsychology that is going to have PhDs, PsyDs, those who can issue these cognitive screenings more readily. So I'm thinking about one that's here local in Louisiana. Their neuropsychology department is an interdisciplinary team. They have a nurse practitioner, they have neuropsychologists, they have those who are trained specifically to give these cognitive tests. And they're also they're gonna they're going to have a more holistic view. Neurology, they can still do some tests, and neuropsychology is actually embedded typically in neurology. So neurology can still do a lot of things, but neuropsychology at least speaks to me in my experience as having, more people on the team, social workers included in that. So when you go to wherever you go, whatever office you end up going to or in this course, it's a process of eliminating potential reversible causes, which I'll have on the next screen, I believe. And then, so that could involve lab tests where they're taking blood samples, they're running those and seeing if anything comes up unusual. They're doing cognitive screening tests. It might be, they might give you words to 3 words to remember. And then a few minutes later, they're going to ask you, those 3 words that I gave you, can you tell me those? It might be a clock drawing test. Tell me what, draw a clock with the hands and the numbers to 10 a.m. So that is a validated test that's going to tell a story about the brain. And then there are many other tests, some of them short screening, some of them very lengthy. And then imaging sometimes is ordered to take a look at the brain. What's the size of the brain? Do we see what are we seeing there? And I say imaging sometimes because a lot of times it depends on the clinician would have to actually check with insurance or sort of write a justification for it to be covered by insurance, because not all insurances want to pay for the different types of imaging. That is changing as research uncovers more benefit from imaging. We're starting to see more of that open up. Same thing with biomarkers of blood. So it's actually a really exciting time as far as the like biomarkers and imaging and some of the new things that are coming out. So I mentioned those reversible symptoms. Here's a list of many of them, some of the more common ones. And when I was talking to a physician, a neuropsychologist about this, in his experience in his clinic, about 10% of the patients that come in with memory complaint have something that's reversible. So first, and I didn't mention this, so dementia, the different dementias that we saw early in the presentation, they're not reversible. There is something biologically going on. And there's not the ability yet to cure it and stop it. But there are some things that could mask as could cause these symptoms of dementia that we saw, but can be reversible. They can be treatable. Sleep apnea. I think it's important. Not everybody gets this done, but I think it's important to request a sleep study, or for your provider to, get a sleep study, see if there's a history of sleep apnea or diagnosed or undiagnosed. Depression, so screening for depression, hypothyroidism, certain medications for older adults. They're on and there are many classes of, I would say, of drugs to avoid for those who are older. One of the biggest culprits being a class called anticholinergics. You will see these in dozens of medications. Some of the more common ones are allergy medicines. They might be incontinence medicines. They could be sleep medications. So they tend to cause confusion for older adults who are not able to process it like someone younger can. So it's really up to, I've had this in my presentation, I think since last December, after seeing, just examples with my friends' parents, seeing confusion, seeing falls happen. So, this could lead to falls. So if you look up anticholinergics, there's actually a really good website called that is a calculator. It's called ACB calculator. I'll have that in the notes. But you can go to this website and you can type in medications, and it will come up with a score. And if it's it will tell you whether there's a high risk, whether you or whoever medication regimen it is at a high risk of an anticholinergic burden, which could lead to falls and other things like that. So this is something that's absolutely preventable. So that's why it's important for people, to be aware of that in other classes of drugs that are for that. And just a brief anecdote. So this happened a few months ago, so I was already kind of aware of this, but my dad went to an allergist who prescribed a medication for him. And it every once in a while, I'll ask my parents to send me their medications names, and they do. And I plug it into the calculator, and it came up as having this one particular allergy medicine had anticholinergic properties in it. So I, told my dad, I did a little more research and told my dad, look, this is what it's telling me, send this, you might want to send this to your doctor so he can, so he can not do this, so he can discontinue this advice. But also, here are some other allergy medications that don't have that burden with them. So it's not just don't do this, it's here are some alternatives. And thank goodness there were some for that and for many medications. So be sure to look into that. Just substitute some of those things. B12 deficiency is something that can be corrected. There are certain infections, and then issues with eyes and ears. And just think about, if you're not able to hear something, that could cause, that might lead many of us, it would lead me to not want to be in as many conversations as I am in, or to withdraw from some social interactions, because I can't hear and I can't participate, and I just want to avoid that. And we could say the same thing about being able to see where we're going, whether it's driving or being in social situations. We'll talk a little bit more about the eyes and the ears as far as risk factors. So many times when we're thinking about all these heavy medical topics and things that are going on, and the deficits, we sometimes forget that we're a composite of body and soul. St. Thomas Aquinas told us that. So we're not just a body, and we're not just a soul. We're a composite of these, and they can't be separated. So in that, we'll start to shift and see, like, what does our Catholic faith say about suffering? And here, we're talking specifically about dementia, and how do we utilize our beautiful and rich Catholic faith along with this medical education that we have to really have a wonderful life that takes care not just of our body, but of our soul. I'm going to check my time real quick. All right. So if there is a probable diagnosis, and I do say probable because the research tells us that we cannot definitively, absolutely say that someone has dementia until after, if there is an autopsy, when they actually get to look at the brain and see who's impacted. I know we can get really close, but probable is still the word that many people use correctly as far as a diagnosis, because you're looking at the symptoms, the behaviors. So if there is a probable diagnosis, and I know I'm not currently in this situation, so this is all easier said than done. But what I've learned many years from caregivers and from physicians and professors is, let's take a deep breath. Take a deep breath. What happens in the next few moments of learning about this condition or probable diagnosis doesn't make or break anything. But we want to be really calm, resolve, and just have this optimism, even if you don't believe it, even if it doesn't make sense in the moment. Just resolve that you and your family can adapt to this situation, to this probable diagnosis. And we'll talk about some strategies later in the presentation. But it is a disability. It's an invisible disability. We just, it's something we can't see. That whereas we can see someone who is using a walker or using a wheelchair, etc., has a cast on their arm. And we're called as Catholics to always trust in God's plan, even when we don't understand it, because we know that He brings good out of even evil or bad things, and it's all ordered towards our ultimate salvation. And this is absolutely not the time to limit activities just because there's a probable diagnosis. So, for example, you would never want to, I'll say never, but you don't want to, it's not advisable to just automatically take the car keys away from somebody when there is a probable diagnosis, Now, if you see the signs, if you see reasons, physical evidence and reasons, not just suspicion, of needing to limit or take away the driving privileges, we don't want to do that unnecessarily. And there are many other things. It doesn't mean you need to stop working or stop the activities that you're doing or stop traveling or anything like that. So I think that thought or that fear keeps a lot of people out of the clinic that don't want to go find out the answer. So want to say that, very clearly, it's not time to limit activities, because it is a disability, and we want we would want anybody that has a disability to focus on their abilities and still be based in reality, of course. And St. Augustine, he says, pray as though everything depended on God, but work, or I would say also adapt, as everything depended on you. So it's a both and, like many things in our Catholic faith. And that brings us to the spiritual works of mercy and the corporal works of mercy. So I'll, not going to go over all of these, but just want to put them side by side. I think many times, as volunteers in our parishes, as medical providers, social professionals, we gravitate towards the corporal works of mercy because they're the things that we see. They're the things we do with our hands. And they're things that most ministries are based on. And really at the expense of the soul of ourselves and the other person, many times we don't think about the spiritual works of mercy, which in the tradition of 2,000 years holds the primacy. And it's not that we have to pick one of these spiritual works over and not do one of these corporal, but it's that both and. We must not, the spiritual works of mercy, should not and don't need to suffer at the expense of the corporal works of mercy. We should really be doing all of that, and in ways that are not adding too much work or burden to each other as well. And some of this will kind of make sense in the rest of the presentation. So the church is a foundation. On the right-hand side is a piece of artwork that Catholic Aging had commissioned by a local Louisiana artist that has Our Lady, of course, and then below her is St. John the Evangelist, the patron saint of caregivers, who we should all be, praying for. Actually, everybody in this painting. To his left is St. Dymphna, the patron saint of brain disorders, but also depression and anxiety, and many other things. And then St. Raphael, the Archangel, who's the patron saint of travelers, because anybody who is going through this is going on a journey. And he is also, as we see in the book of Tobit, is able to heal as well, has intercession for healing. So we look to Our Lady and these saints in these times, whether dementia is involved or not, because many people can be caregivers of someone who has some other kind of condition that's limiting many things that they can do. But as you know, in our Catholic faith, we have that long-term view. We know that we're only here, on Earth in the whole span of our life. We're here on this earth a very short time. So we know that any suffering, as bad as it is and as ambiguous as it may feel and as painful as it might be, we know that it's just for a short time, and it's to really to kind of chip away at our faults and to help us grow in virtue. We know that we have the intercession and the example of our Blessed Mother and of the saints that I mentioned here, and there are so many others that impact us, in suffering or in medical care or as patients or providers. So we have the beautiful example, not just them to intercede for us, but here I have the example. There are so many saints that suffered either physical, mental, or persecution, that we look to them as those who could do that and to inspire us. So instead of maybe athletes and actors and actresses that the world tends to admire, these are the people that we should. These are the saints that can work on our behalf, but also we look to as an example to get us to virtue. there's the idea of redemptive suffering that is not, talked about enough, especially in medical care and in secular medical areas. But that idea that, we join our suffering with that of Christ. He suffered, of course, and he did enough. He suffered enough for our sins and for our salvation, but we are all invited to participate in that with him. None of us will escape that. We will participate in some way. And in that way, it's an honor. It really is. Now, I know a lot of these things are, like I said, with some of the previous things, easier said than done. But, if these are not things that you understand already, hopefully these are seeds that are planted. And, it's personally, being in this ministry and working and collaborating with people has been an immense blessing to me, because these are things that were not part of my formation growing up, even in Catholic New Orleans, a very traditionally a Catholic area. These are a lot of things that were missing from my formation in school. There's pastoral care, of course, from priests, from deacons, from religious. Every Catholic or even non-Catholic should be able to go to the parish and to receive accompaniment in the spiritual and the corporal works of mercy. And that's something that our ministry, it tries to inspire and equip people and bring awareness to parishes. We have sacramentals, of course, and hopefully you're availing yourself to these things. And it's a good thing that we have the Catholic Church, because there is so much negativity that can come with aging and that can come with being caregivers. It can offer its own special, I'm going to say special, but particular temptations and vices. And I think it's worth meditating that our golden years are the final spiritual battle. It's Satan's last chance of, pulling us into vice. And here I'm going to show you there's no short list of opportunities for vice. And this is a short list, but it is long in reality. So I'll cover a couple of these. So these are things that I see people talk about, and it could be like in modern contemporary society, of course, but sometimes people bring these things up in support group. So for example, despair or loss of hope. So to not have, to lose your hope in your condition, whether it's dementia, whether it's caregiving or anything else, is to have a lack of faith. Many people I could see people being angry with God, like, why did this happen to me? Why did I get this disease? Why did I get that disease? Why did my loved one get this disease? Sometimes with dementia, there are people who refuse charity. People want to come in and sit with them or offer some kind of assistance, and it's like, pride steps in. And at the same time, it takes a lot of humility, which I think we all are striving. We're all striving for humility, but it takes a lot of humility to accept help from people. The next time that someone offers you help, think about, pay attention of how you respond to that. Because I know even myself, sometimes whether I'm lifting something or carrying, or, I don't want to trouble somebody, I can take care of, they don't need to help me. So, but, I could stand to grow in that as well. Certainly in modern society, we see ideas and temptations of assisted suicide. That idea that, we can determine when we can leave this earth because we don't like our set of circumstances. And I've also seen resistance to faith. I've seen, and that sometimes is not believing things, or, that we are called to believe as Catholics, or even just, someone not going to confession for decades. I've certainly seen that. So all these things, on the right-hand side, these are things that I especially see with caregivers. And I'll give you an example. So bitterness and grudges. So in the support groups, it's not uncommon to hear a caregiver talk about, I have 3 siblings and they live in town and they're in denial and they don't want to help. And, so on. And, they're very frustrated, and there's some bitterness. So it's something very normal to have, but we are called to pray for them. We're called to try to accept that suffering right there, and the graces from that to be towards a change of heart for them. We might be envious of people who are not having to care for a spouse, and certainly with as far as finances go and resources, many people are tempted when they now have power of attorney, or they have responsibility for financials of someone. The little devil pops up on your shoulder and say, you know what, it's fine if I buy this TV for myself. Mom's not going to miss the money. I'm doing all this work for her. My siblings are not. So they kind of, these things just kind of crop up, and you have to be prepared for them. And in this slide is not to condemn anybody or judge anybody by any means. It's really just to kind of point out some of these things that pop up, and they should be things that hopefully we address, because these will happen. These will all, not all of them, but these are things that are going to be common for caregivers and those who are suffering, those who are aging. And so if we have that awareness, just like we have this awareness of dementia, we can start to look some things. But we have some good news. We do have the Catholic Church, and we do have, this is a beautiful prayer that I learned about this past January of 2023, and it's the Light of Christ prayer. And it's for the conversion of others. And it could be in the sense of converting someone to bring them back to the faith, but it could also be the conversion of a sibling's heart, or another family member, or a friend, to sort of wake up to the reality that you need their help, and we need a change of, we would love to see a change in their heart, to see them step up. And we do that by not being bitter at them and not showing unforgiveness, but for praying for them. And this is of course is not the only prayer, but this is just a powerful prayer I wanted to share with y'all. That's from Liber Christo, or also known as Monte Cristo. This is Father Ripperger's team out of Colorado that specialty is candidly, it's spiritual warfare. They train priests, they train lay people, and they will tell you that spiritual warfare is prayer. All of us are called to be in the battle in the form of prayer. We won't do a lot of the things that they do, of course, as priests or even their assistants, but we're all called to pray for others for their conversion. So I'll get on with the prayer now. So you can see it on your screen. May the light of Christ shine upon Matthew, that he may see himself as you see him, and that he may see and that I may see him as you see them. And this is a prayer that I pray for my wife, my children, my extended family. I prayed for them every day as part of the Rosary. Pray for them by name, because we all can come. We all are, in a sense, are in a need of conversion, if not obvious conversion, but just coming closer to Christ. So this is something that doesn't say, God, make them help me. It's not being very specific. It's not being prescriptive. It's calling for a change in their heart, for God to create some kind of circumstance, for them to hear something, not from you, but from somewhere else. And it's sort of a light bulb or a lightning bolt to them, so they start to see themselves as God sees them. Because how wonderful would that be if I, Matthew, really understood how much God loved me? I would just sit there and meditate all day. I would just want to think about that and bask in his love. And I would give that love to others. So this will also be of course, in the slide deck. And I encourage everybody, certainly all the clients that I meet with at my Catholic doctor, I introduce this prayer to them, because many of them are, going on this journey, maybe not by themselves, but where there are people on the sidelines who they need to be in the game. And it's important to, while we talk about, we kind of went through, 2 slides where we're talking about negative things. And it's important to recognize the blessings that we have, not just from the church, but from being a caregiver and from aging ourselves. So if we're aging, we have more time to pray. We're presuming that we are retired from our profession. We still might be really busy, but there's more time to pray. There's that opportunity to pass on to the next generation our faith, whether it's grandchildren or you're teaching at the parish, or you're just teaching in your neighborhood and you're an example and witness. Pope Francis has written a lot about this and spoken a lot about the how powerful the older generation is to passing on the faith. There's that opportunity to in praying, to offer that willingness to suffer, doing that for souls. So I think we commonly hear the phrase "offer it up," and we're offering it up. Specifically, we're offering up that willingness to suffer for a conversion of others, our family, for their and for many blessings for them. There's more time, presumably, for Mass and adoration. On the caregiver side, and for spouse side, this is an opportunity to fulfill our duty to our parents, which is called piety, and to honor our wedding vows to our spouse, to die, to continue to die for them, and to forgive others. We talked about redemptive suffering before. So, and a lot of it is coming down to uniformity with God's will. A really short book, almost you could probably call it a pamphlet, I recommend to everybody, is Uniformity with God's Will by Saint Alphonsus Liguori, and he gives example after example of his own life or with the saints or from Scripture of how the suffering that's going on right now in our lives, and we all have some kind of sense of that, whether it's caregiving or otherwise, is that there's a reason for that. It's for our salvation, and it's really up to us not up to us, but it behooves us to meditate on that, not to just say, I wish the suffering was over, but to try to meditate on why this might be happening. And God's, he's paying special attention on us. He's trying to get our attention, is one of the things that he talks about. But just a wonderful book. I would say it's not a little pamphlet to read through. I tried doing that. It's more it's more like read a few pages and then just, meditate on it and how powerful it is. It's even if you're not one especially experienced in meditation, try that book, and I think it will put you in that into that practice automatically, because it's so powerful. So getting into some of the shifting from spiritual to getting to some of the earthly pragmatic things, it's important that if there's a probable diagnosis, that you build the team. And yes, I have a priest there at the very top, and it doesn't mean he's the quarterback of it like the primary care physician who is, but it's that when you have good news or you have unfortunate news, you go to your Father, right? You go to them for advice, you go to them for the support, you go to them for prayer, and it's no different. So let your priest know that what you're going through, what your family members going through, so that they can better support you, or enhance the support that they're giving you. Next is having a good primary care physician, somebody who is confident in this, or wants to learn and continues to learn. A geriatrician is ideal, but we have very few. I'll put it this way: we don't have enough geriatricians for the amount of older adults in our country, so that's unfortunate. But someone doesn't have to be board certified in geriatrics to be knowledgeable. You're looking for someone who has an interest and loves this population, who loves older adults, who sees it as their mission to continue to support and help them live a full life, and to adapt with any ailments. Many things will not be able to be cured, but it's that physician and that team that persists in saying, this can be adapted to. Neuropsychology. I mentioned sometimes a psychiatrist is appropriate for those who are not aware. So a neuropsychologist, I mentioned, is a PhD. They're not an MD like a neurologist or a psychiatrist is. So they can't prescribe medication. But so you still might, even though you have a neuropsychologist, it's still appropriate to have at least so that you can consult with, or your providers can have a neurologist or psychiatrist if that is ever needed. And sometimes that is needed. We'll talk more about medications in a moment. And then consider palliative care. Many people, I think they picture palliative care as end of life hospice, and certainly hospice is part of palliative care. But palliative care, it's good to see as a extra layer of support of someone that can help look at the symptoms when the specialists in primary care are having a challenge controlling that. I'm seeing my time, so I'm going to try to speed up. So social worker, not every office is going to have one, but it's important to ask for one. Or if that department does not, say, hey, could another department could another department loan me one, or how can I see a social worker? A pharmacist is sometimes appropriate, especially with the things that we talked about with the anticholinergics and other high-risk medications. Attorney, financial planner, a personal trainer. Some people, in my experience, I've learned they're not really interested in going out to work out for their caregiver. So the caregiver has a challenge convincing them to get up and stretch and move. But if you bring a personal trainer in, they'll kind of, sometimes people will respond to that person who's here specifically for that purpose. Having a counselor and a therapist, I think, is important. And sometimes that's a social worker who's a therapist, who's licensed as a therapist. Speech therapy is sometimes appropriate, especially for PPA, primary progressive aphasia. Occupational therapists, these therapists help you figure out how to adapt your home and other situations so that you can be more adept at some of the instrumental ADLs, or just the plain standard ADLs. And of course, nutrition. Lifestyle modification, speaking of nutrition. So these are 5 things that not just I, but the research recommends for those who want to promote a healthy brain, where someone who does not have dementia, so especially talking to the caregivers out there, but also someone who does. These are only things that can really help someone in all these areas, but these are things that the research tells us will promote brain health and hopefully stave off dementia if it's in our future. Eating well, excuse me. So eating well, the Mediterranean diet and DASH diet show promise. Intermittent fasting is something also that I'm very fascinated with, and how it affects metabolism and the fuel it's burning. Your body is burning when you're intermittent. Physical activity, and that's the best activity. Of course, getting the heart rate up for 20 minutes several times a week is optimal, but really it's and that could be swimming. It could be any activity that you or your loved one enjoys and will actually stick to, not something that someone tells you to do that you're going to procrastinate. It should be enjoyable. Elliptical, bicycle, swimming, walking, etc. Intellectual stimulation, same thing. Many times Sudoku or brain games on the computer are, what is recommended, and there's not a whole lot of evidence behind those things. So I also say, just like with physical activity, do things that you're curious about or that you're interested in that are enjoyable. Socialization, stay involved as much as you can with your church parish, with fraternal organizations, with prayer groups, with voluntary associations, gardening clubs, etc. And something that does not get mentioned much, but is actually the number one modifiable factor per the research, is having a hearing device. So when people and the jury is still out, there are 2 to 3 reasons why they think that is the case. But if you have hearing loss, if it's not optimal, they recommend getting some kind of hearing device so that you so that you're able to communicate. So it's not blocking messages that normally you would hear. So there's actually many reasons, and that would be a very interesting talk to hear someone give. But hearing is one of those things that we can modify by getting checked out by an audiologist, maybe screened by primary care, but also going to see an audiologist, getting the right fit, getting the right device, learning how to use it and keep it clean, et cetera. So huge, fascinating topic, but please add that to your list of things you don't hear about much. Coming towards the end, y'all, behaviors or communication. So dementia can take away someone's ability to express their needs and their wants. And that could be, you can see on the right-hand side of the screen, these are things, people who are in pain and can't express it, people who are uncomfortable, like temperature-wise, clothing-wise, the ability, the need of having to go to the bathroom, to toilet themselves, their intake, meaning like, are they hungry, are they thirsty, and then their energy level, are they super like ramped up and like need some kind of activity, so they're gonna leave out the house when they shouldn't, or are they just so tired that it's making them not feel good, making them irritable. So see these things as expressing needs and wants that we could possibly help facilitate with, rather than something that's annoying you, or something that's bothering you. So we want to presume everything that they do is a purpose. There's a purpose behind them, trying to take their shirt off when they're in Applebee's, or, just getting restless where they are. So we must become detectives and look at these things on the right-hand side. Palliative care. Since I already talked about this, I'll just mention there are two outstanding videos, not because I interviewed, but because Dr. Tom Carroll, who's also a provider on My Catholic Doctor, he explains myths about palliative care. It even gets into some of the medicines and misconceptions, what it is, the insurance benefits. He does a wonderful job in these two interviews. So this, of course, will be in the slide deck. You'll be able to click on that. And then, the last thing is, I encourage you to join. If you like this and other information, you can sign up for a free private email newsletter every Tuesday. You can go to dementiarosary.com, or you can, with your smartphone, you can scan that QR code. We are on social media where we do Facebook, we do a short prayer on Facebook just about every morning. And then, of course, I'm available to meet with families and caregivers at mycatholicdoctor.com, really just to kind of figure out things and come up with a plan going forward. So I appreciate everybody's attention.